Welcome back to the Deep Dive. Today, we are stripping everything back. We've cleared the desk, and we're focusing on pure, high-yield revision.
Exactly.
If you are a plastic surgery resident, or, specifically if you're prepping for the FRCS or similar board exams, this deep dive is for you.
Yeah, this is tailored.
We're doing a focused, rapid-fire review of dental anatomy and occlusion.
Precisely. And I think it's important to frame this correctly. This isn't about the philosophy of dentistry. We're not learning root canals here.
No.
This is the nuts and bolts you need to describe facial trauma, plan a mandible reconstruction, and, actually talk to your ortho colleagues without looking lost.
Right, it's the absolute foundations. So we're talking dentition basics, directional terminology, which can be a total minefield.
Oh, absolutely. In the heat of the moment.
Yeah. And the numbering systems, and of course the big one.
Yeah.
The angle classification. We're going to run this as a direct question and explanation session. We want this to be efficient.
Efficient and high yield. That's the only goal.
Okay. So before we jump in, a quick request for our regulars. If you're getting value out of these, please take a second to rate the show. It really helps.
It does. And leave a comment. Let us know what topic you need us to cover next. We build these deep dives based on what you need for your exams.
And one more thing, if you want to go deeper, you really need to check out the premium subscription.
That's where we keep the journal club and our clinical cases deep dives. We just put up a case study that applies this exact theory to a panfacial fracture.
So you get to see it in practice.
It just solidifies everything.
Absolutely. Go premium. Okay, let's get to it. Section 1, dentition and morphology. Let's start with the absolute baseline numbers.
Okay.
Break down primary versus permanent dentition for us.
So we have two distinct sets. Keeping them straight is vital, especially with pediatric trauma where you might see a mixed dentition.
Right.
First, you've got the primary dentition. You'll hear them called baby or deciduous teeth. The magic number there is 20.
20. And just to be clear, that means no premolars and no third molars in that set.
Exactly right. Just incisors, canines, and molars. Then we move to the permanent or secondary adult dentition.
Okay.
That consists of 32 teeth. That's assuming, of course, that the wisdom teeth, the third molars, are present. But 32 is the number you need to know.
Now, architecturally, how do we orient ourselves?
Yeah.
Because just saying top and bottom feels a bit imprecise for an op note.
Yeah, you can't do that. We divide the mouth into two dental arches. You have the maxillary arch, that's the upper jaw fixed to the skull, and the mandibular arch, which is the movable lower jaw. Then, to get more specific, we divide those arches right down the midline.
Okay, so that gives us quadrants.
Exactly, 4 quadrants. So you're not just looking at a tooth on the right, you're looking at the maxillary right quadrant or mandibular left quadrant. Much more precise.
Okay, let's drill down into the teeth themselves. Classification by morphology. If I'm looking at a tooth, what are the defining characteristics?
Sure. It's all about form following function. So right at the front, you have the incisors.
Right.
You identify those because they have a flat, straight, biting surface. We call it an incisal edge. They're built for cutting. They're the scissors.
And moving out from there.
Next up are the canines, also called cuspids. The key feature is in the name cuspid. They have exactly one pointed cusp, designed for tearing.
And these are structurally critical, aren't they? From a surgical view.
Huge. They have the longest roots in the entire dentition. That long root creates the canine eminence on the maxilla, which is a critical pillar for facial structure.
So losing a canine actually changes the face.
It can, yeah. You lose that skeletal support.
Wow. Okay, moving back from the canines.
Then you hit the grinding zone. You have the premolars or bicuspids. Again, the name gives it away. They usually have 2 cusps.
A buccal and a lingual one?
Typically, yes. And finally, the molars, the heavy lifters. These are identified by having 3 or more flattened cusps on a wide occlusal surface. They just pulverize food.
You mentioned cusps a few times. Let's just clarify the vertical structure. What are the key anatomical landmarks we need to lock in?
Okay, 4 terms you need to be totally fluent in. First, the crown. That's just the part of the tooth you can see above the gum line.
Covered in enamel.
Correct. Second, the root. The portion below the gum line embedded in the bone.
Simple enough. And the surface details.
That brings us to cusp. Formally, it's a pronounced elevation on the biting surface. It's the mountain peak.
Okay.
And fourth, you have the groove. The groove is the depression or line that separates those cusps. It's the valley between the mountains.
Perfect. Let's move to section 2, directional terminology. This is where things get messy in trauma descriptions.
It's a classic mistake. You can't say front, back, inner, or outer. The mouth is a curve, so you need the specific compass of the oral cavity.
So I'll throw terms that you give me the precise definition. Let's start with the cheek side. Buccal.
Buccal means towards the cheek. You use this for the posterior teeth, premolars and molars.
And for the front teeth.
That would be labial. Towards the lips. It's a subtle distinction, but accuracy matters. You wouldn't say the buccal surface of a central incisor.
Got it. Okay, inner surfaces. Distinguish between lingual and palatal for us.
So lingual means towards the tongue. You can use that for both arches. But palatal is specific. It means towards the hard palate.
So only for the top teeth.
Exactly. You only use palatal for the inner surface of the maxillary teeth.
That makes sense. Now, the one that always confuses people because it's relative. Mesial versus distal.
Right. You have to visualize the curve of the arch. Think of the midline, that line between the two front incisors, as your magnetic north.
Okay.
Mesial means towards that midline, following the curve.
And distal.
Distal is away from the midline, moving back along the curve.
So on a first molar, the mesial surface touches the premolar in front.
Correct.
And the distal surface touches the second molar behind it.
You've got it. Mesial is front-facing along the curve. Distal is back-facing, towards the apex, so towards the tip of the root. If a fracture extends apically, it's running deep into the bone.
Occlusal.
That's the biting surface. We typically use it for posterior teeth. For incisors, you might say incisal edge, but the general plane is occlusal.
And the last one, proximal.
Proximal just means the surfaces that touch the neighboring teeth. So the mesial and distal surfaces are both proximal surfaces. It's where they approximate each other.
Excellent. Let's shift gears. Section 3. Tooth numbering systems. This is tricky because depending on where you trained or what journal you're reading, you see different systems.
It's a crucial point. Misidentifying a tooth in a surgical plan is a never event. You have two major players, Palmer notation and the universal numbering system. You need to know both.
Let's start with the UK focus, the Palmer notation.
Okay. The Palmer system is very popular with orthodontists because it's so visual. It's quadrant-based. You only count 1 through 8.
So every quadrant has a tooth number 1.
Correct. You start from the midline and move out. Your central incisor is always a 1. Your canine is a 3. Your first molar is always a 6. Your wisdom tooth is an 8.
So how do you write that down? How do you distinguish, say, the upper right 6 from the lower left 6?
You use a symbol. It looks like a right angle, basically drawing the corner of the mouth that the tooth is in. You have 4 of them, and the number sits inside that angle.
And for kids, in Palmer?
For primary teeth, they just swap numbers for letters A through E starting from the midline, so central incisor is an A.
Okay, now let's cross the Atlantic. The universal numbering system. Standard in the U.S. This one's a continuous sequence, right?
Correct. It runs from 1 to 32, no quadrants, just a single continuous count.
Walk us through the path. Where does it start?
You start at the patient's top right. Tooth number 1 is the patient's right maxillary third molar. Even if it's missing, that spot is number 1.
And then you go across.
You count across the entire maxillary arch all the way to the left side. So the top left third molar is number 16.
Okay, that's the whole upper arch.
Then you drop straight down to the left mandibular third molar, which is number 17.
And then you count back across the bottom.
You got it. From left to right, ending at the right mandibular third molar, which is number 32.
So it's a big circle. Top right is 1, top left 16, bottom left 17, bottom right 32.
Exactly. A good anchor is to remember the wisdom teeth are the corners. 1, 16, 17, and 32.
And does Universal use letters for baby teeth too?
It does. Same path, upper right to upper left, drop down, lower left to lower right. But it uses letters A through T.
All right. Let's put this all together. Section 4, occlusion and angle classification. This is probably the highest yield topic for the boards in this whole deep dive.
Without a doubt, you cannot describe a patient's profile or plan an orthosurgery without understanding occlusion.
So let's start with the definition. What is malocclusion?
Simply put, it's an incorrect relationship between the teeth of the two arches when the jaws close.
And to classify it, we use angles classification. Now, this system relies on one specific landmark relationship. Let's slow down here because this is the most important concept. What is that reference point?
Engel based his entire system on the relationship between the mesiobuccal cusp of the maxillary first molar,
The top first molar.
and the buccal groove of the mandibular first molar.
The bottom first molar. I'm going to repeat that because it's vital. We are looking at the mesiobuccal cusp on top and the buccal groove on the bottom.
It's a key fitting into a lock. That single interaction dictates the classification of the entire face.
So describe normal occlusion using those landmarks.
In normal occlusion, that mesiobuccal cusp of the maxillary first molar fits directly into the buccal groove of the mandibular first molar. It just slots right in.
And the other teeth are aligned.
Right. And all the other teeth are in normal alignment.
Okay, so then what is a class I malocclusion?
This is where it gets a little tricky. A class I malocclusion actually has that same normal molar relationship. The key fits the lock perfectly.
So the molars are fine.
The molars are anchored correctly. The malocclusion part comes from the other teeth. There might be overcrowding, rotations, misalignment somewhere else.
Okay, now it gets interesting. Class 2 malocclusion.
In class 2, the mandibular first molar is positioned distally relative to the upper molar. The lower jaw is essentially slid backward.
And at our landmark, what does that look like?
The specific marker is that the buccal groove of the mandibular first molar is distal to or behind the mesiobuccal cusp of the maxillary first molar.
What does this patient generally look like?
This usually correlates with a retrognathic profile. Think of a weak chin or a convex facial profile.
Okay, so class 2 is distal. That brings us to class 3.
Class 3 is the opposite. The mandibular first molar is positioned mesially relative to the upper molar. The lower jaw is projecting forward.
And landmark.
The buccal groove of the mandibular first molar is mesial to or in front of the mesiobuccal cusp of the maxillary first molar.
And the profile here is prognathic.
Exactly. A prognathic appearance, the lantern jaw, or an underbite.
So it's crucial to visualize that. Groove centered is class 1. Groove back is class 2. Groove forward is class 3.
If you can visualize that lower molar just sliding backward or forward, you will never get an angle classification question wrong.
All right, let's round this out. Section 5. Bite anomalies. First, give me the distinction between overbite and overjet. These two get mixed up all the time.
They do. Easiest way to remember is overbite is depth, overjet is distance.
Break that down.
Overbite is vertical. It's the amount of vertical overlap, how much of the bottom teeth are hidden by the top teeth when you bite down.
So a deep overbite is when you can't see the lower incisors at all.
Exactly.
An overjet.
Overjet is horizontal. It's the horizontal projection or distance between the upper and lower incisors. If the upper teeth stick way out in front, classic buck teeth, that's a large overjet.
So overbite vertical, overjet horizontal. Got it. What about when things don't touch? What's an open bite?
An open bite is exactly what it sounds like. A lack of vertical overlap. Usually in the front, you see a visible gap between the upper and lower incisors when the back teeth are touching.
And we see that with condylar fractures.
Critically, an anterior open bite is a hallmark sign of a fracture.
Finally, what is a crossbite?
A crossbite is a transverse issue, a discrepancy in the buccolingual relationship. Normally, the upper teeth sit outside the lower teeth like a lid on a box.
Okay.
In a crossbite, that's reversed. The lower teeth might overlap the upper teeth on the cheek side.
So summarizing this, why does this all matter for the resident listening right now?
It means when you look at a patient, you have the vocabulary to map the terrain. You're not just seeing crooked teeth. You're seeing a class 2 malocclusion with an anterior open bite and a significant overjet.
And that changes everything.
It changes how you plan your treatment, how you reduce a fracture, everything.
And that brings us to the end. We've covered the entire landscape of dental anatomy basics in, what, just about 15 minutes?
If I could leave you with one thought, consider the precision of angles classification. It's fascinating that the entire classification of a patient's facial profile is anchored on the relationship of a single cusp on a single tooth.
It really shows how interconnected it all is.
It shows why the details matter.
That's a great perspective to end on.
So next time you're in clinic or looking at a scan, try to identify that molar relationship first. Make it a habit.
And before you go, please rate the show. It helps us keep these sessions coming.
And seriously, go get that premium subscription. The clinical cases analysis we released last week directly applies these classifications. If you want to see how this dictates where you put your plates and screws, you don't want to miss that.
Thanks for listening. We'll see you in the next deep dive.